I shall start off with the introductions of my panelists. Dr. Ronnie George, he'll be here in a moment. He's stuck in another IC, so he really doesn't require any introduction. He's there in all drishtis and all glaucoma related meetings in the state. He is the Director of Glaucoma Services and Director Research at Shankara Nethralaya in Chennai. He has received numerous awards and held various positions in prestigious societies and journals. Dr. Meena, she is a Senior Consultant and Head of Glaucoma Service at Shankara Eye Hospital, Bangalore. She finished her PG in Ophthalmology from Arvind Eye Hospital, Madurai, and has worked at numerous institutes in Hyderabad and Pune before coming to Bangalore. She has participated in various drug trials and has presented various national and international conferences. Dr. Thomas George, he completed his PG training from CMC Vellore, followed which he worked there as a tutor. He subsequently joined Kerala Government Medical Services and worked initially at Government Medical College Alleppey and later at RIO Trivandrum. At present, he is working as Senior Consultant in Glaucoma and Cataract Service at Chaitanya Eye Hospital and Research Institute, Trivandrum. Dr. Kiran, he completed his MBBS from Government Medical College, Trivandrum, and he earned his MD in Ophthalmology at RP Center, and he graduated with the Best President Award. He subsequently worked as Senior Resident in Glaucoma and Cornea at the same institution till 2010, and after completing a fellowship, he joined Vasan Eye Care, Trivandrum as Consultant Glaucoma. He is currently Consultant in Glaucoma and anterior segment at Precise Specialty Eye Care since 2013 at Trivandrum. I think we shall proceed with the cases. So the first case is that of a 70-year-old male patient who is a known hypertensive since past 24 years, and he has complaints of decrease in vision in the left eye of 1 year duration. So coming to the findings, he has a vision of 6/9 and 6. He has early cataract in both eyes. The intraocular pressure is 22 in the right eye and 29 in the left eye. Gonioscopy shows open angles. Disc is, I'll show the photo of the disc, the CDO ratio of 0.75 in the right eye, while in the left eye it's almost total cupping with RP changes at the macula. So this is the disc findings. In the right eye it appears to be normal, while in the left eye you can see it's almost total cupping. The field evaluation shows early scotomas towards the somewhat like a nasal step in the right eye, while the left eye shows advanced glaucomatous changes, field changes. The OCT mirrors these findings, while the pachymetry here is 590 in the right eye and 594 in the left eye. So coming to this case, now it's a unilateral case, and the left eye is more affected. So the thing here that I would like to ask is, this is probably a primary open angle glaucoma with one eye more affected compared to the other eye. Now, madam, I'll start off with you. Like, how would you like to proceed with this case? According to history, there is no specific risk factor that the patient is telling of.
Yeah, so first of all, I think one eye is advanced and one eye is definitely going to follow the other. So one is to keep a target IOP. That is important considering the CCT, which is little towards the thicker side.
Yes.
So definitely one eye, probably I will keep somewhere around 14 to 16, and the advanced eye probably a little lesser than that. So first and foremost, considering the age, 70-year-old and hypertensive patient, I think there are no other risk factors. So to bring it down, probably we might just start off in a practical situations, we might start off with the maximum medication possible, especially for the left eye, because you have to almost bring it down to more than 60%. If you see 29
yes.
to almost more than 60%, you need to bring it down. And since he doesn't have as such any contraindications to give any of the medications, I would like to start the patient on the maximum medical therapy and probably review the patient again Usually my pattern is around 3 to 4 weeks. I review the patient, and of course we have to understand the patient's other status, like the availability of a caregiver, as well as the affordability and the accessibility for our treatment.
So would you like to start on a combination, or would you always start with one drug and assess it and then start?
No.
Okay.
Because see, theoretically probably that's a very good option to think about, but considering the patient's practical consideration of coming back to us,
Yeah,
I
okay.
would prefer to start the maximum
Combination itself.
med combination, sir.
Any opinion from the other panelists?
It all boils down to how often the patient can follow up.
Okay.
If you can start a PG analog and see the fellow in 1 week and see the response and then add on, that would be what I would prefer, because not everybody responds to every drug. So if we start with a combination, you don't know which one he's responded to, which one is not. So that option is not open. Early cataract, so we're not contemplating immediate surgery, which is a good thing here. We can figure out whether we can medically control both eyes. Aim, of course, is 1/3 reduction to start with, but 0.9 you would want it to go into the low teens anyway,
yes.
which is difficult medically. We are looking at combined cataract trap in the presence of a cataract here. But that is down the line. We'll try medical first.
And regarding use of prostaglandin, do we always start with prostaglandins, or depending upon our target, do we start some other medicine or something?
Yeah. So if there are no contraindications and the patient can afford it, it's a prostaglandin all the time. Because you might see, this business about tailoring, I want 20%, therefore I'll use a drug which gives me 20% is wrong. You might as well give the most effective drug with the fewest systemic complications, and that's a prostaglandin. And I have seen 70% pressure reductions with the prostaglandin. I've seen patients with 45 coming down to 16, 17. So I would start him only on a prostaglandin. And one thing that I'm sure you have assessed this patient very carefully, but if you see anything like this, then you have to first rule out a secondary cause. This sort of asymmetric disease, you might see just half a clock out of angle recession, some pigment sitting somewhere, something. So sometimes that will tell you the cause, and once you know that it's secondary, you're not that concerned. Of course, IOP being 22 in the right eye could suggest that there is asymmetric disease.
But I think in the right eye, there is an evolving nasal step, in fact.
Yes, yes.
So,
Yeah, so I will search.
My concern, here, suppose we have medically started him on a prostaglandin in both the eyes, and in the left eye, now we have, because we have not reached the target pressure, we have added on one more bottle. Let's assume that bottle contains 2 medications. So you have now 2 bottles and 3 medications. Now, this patient has got early cataract. This patient, he's already complaining of a visual loss. Now that I assume is because not of the cataract, because of the severe glaucoma, because he has early cataract in the other eye and similar vision, he's not complaining of vision loss in the other eye. Now in such a circumstance where the IOP, as far as you are concerned, the target intraocular pressure, let's say I would still keep it at mid-teens considering the central corneal thickness, but we have followed up the patient very aggressively, every 4 month fields in the left eye to make sure it is not progressing. But now his cataract has progressed and the vision has dropped down to 618. At that point, would you do a cataract surgery alone, or will you want to go for a combined surgery? That is my question.
Concern.
Yeah, so that is, to me it would depend on what the time period is. If you have had 3 years of follow-up and the patient has not been progressing and is otherwise systemically okay, I might even consider doing only the cataract alone. But generally my rule of thumb is more than 2 drugs, whether it's 1 bottle or 2 bottles, I would do a combined surgery.
Okay. I think we'll go on to the next case.
Sir,
if it is
actually,
okay.
more than 2 drugs, many a time it's better
Okay.
to think of combined.
There is one more aspect. We're eventually having to deal surgically for the cataract. And if it's more than 2 drugs running for a long time, and at that point we need a trap, the trap is more likely to fail because of the conjunctival priming by the drugs. So,
Okay. I think we'll go on to the next case. So here we have a 63-year-old lady who has thyroid dysfunction. She is also on drugs for dyslipidemia. She has family history of glaucoma, and she has actually come for irritation and swelling of the lids. So the best corrected visual acuity is 6.6 and 6 in both eyes. Early cortical cataract. Gonioscopy shows open angles. IOP is only 16, and here's the disc. So you have thinning both superior as well as inferior poles in both the eyes, along with RNFL defects. The fields also show a superior arcuate scotoma, inferior step in the left eye, and the right eye is showing both superior as well as inferior arcuate defects. The macular program shows these changes, and OCT, both of the macula as well as the RNFL, shows corresponding changes. The CCT is normal. Now here we have probably something like a normal tension glaucoma. IOP is 16, normal CCTs. Now, how would you proceed, Thomas, sir? Like, what would you do?
My first question is thyroid dysfunction. Has she ever gone through an orbitopathy? Has she ever had an orbitopathy
No,
situation?
she has not had an orbitopathy.
So then we have to think of this as a possible NTG.
Okay.
Because this could be something that has happened and it's static also. And the pressures are almost as low as what we can get medically, typically.
Role for facing?
Yes, absolutely.
Definitely.
Diurnal facing is there, and that has to be done. We may, with the pressure, I'm assuming the pressure is 16 in facing also, we may start at the PG analog because it has no systemic problems.
Okay.
Practically no systemic problems. Other than that, before I put down that we need aggression here, I need to see progression on fields. It could be a one-time field like
One-time
this
event
and-
that had happened earlier, and then it is staying stable.
There is a complaint of irritation and swelling of lids which you have put up. Any specific reason for putting that up? Is that because
Nothing much. I thought it was just dry eye, postmenopausal.
okay, because in the context of thyroid dysfunction, I'm assuming that the patient does not have any proptosis or things like
no
that.
thyroid eye disease as such. But we are seeing many thyroid patients because we have a good oculoplasty wing. So thyroid patients with raised IOP. Many patients, the IOP, you wonder whether to treat or not. The fields and the discs are healthy. But how do you go about that? Because lots of thyroid patients are coming, you try to reduce the IOP, IOP doesn't go down that much. There is no chemosis or raised episcleral venous pressure per se, but
Proptosis is there.
yes, proptosis
That
is
is usually in such cases, I think the endocrinologists do consider, giving them active decompression through systemic steroids and things like that in such cases where there is proptosis. Unless those things are done, the pressures may not really come
may
down
not
that
come down.
much.
Yeah.
And one more thing I just wanted to just get a clarification on from the panel in general. So this is now, suppose this is an NTG and we are assuming that the thyroid dysfunction and dyslipidemia, these are all under control. All the parameters are under control. Naturally, I think at this stage, we might, especially in the setting of family history also, we start the patient on a prostaglandin and we follow up. So do you, at this point of time, when you have made a primary diagnosis of NTG, go for more aggressive systemic investigations? What I'm saying is, do we do a halter, or do we send the patient for a cardiology evaluation, a Doppler scan of carotids? Do we do it at this stage, or you wait and see if there is a progression, then you aggressively go after those systemic conditions?
I personally prefer to do all the investigations at this visit itself. Definitely clinically whatever I could do, I will try to do, like I did pulsations and things like that, ask for little deeper history of sleep apnea kind of picture, and of course migraine, all those usual what we see, what the patient may not think it is relevant
Systemic, problems
evaluation.
that
I
might be-
prefer to do in the first visit so that we are little clear about what next to do. Sir?
Yeah, I would do a good
Systemic
history.
evaluation.
No, I would do a good history.
Okay.
In this patient, to me, this is most likely a POAG. We are just seeing her at a trough. She's got a family history of glaucoma. So the most likely association is maybe she has got sort of 6 to 8 times greater risk of having POAG.
Yes.
So if that's a situation, this sort of a field effect and all that, when you follow with time or you do phasing, you will find that at some time points you are seeing pressures in the 20s or a little higher. So I would not do the entire NTG workup at this point because of that significant history, provided I can confirm that the sister really has glaucoma.
Okay. One thing I want to ask you, sir, specifically regarding thyroid eye disease and glaucoma. So, do you get lots of patients with raised IOP, and how do you?
We do, and basically sometimes they will not have raised IOP, sometimes they'll have raised IOP, and one useful test to do at that time is ask them to look up or look down. So when that muscle gets tethered, your pressures go up. If that is the case, then you know that the thickening of those muscles is actually causing a problem.
Okay.
And then we just tell them that let's be a little bit more aggressive. And most patients, once they start therapy, that just settles down. We have few who have been really difficult to manage, and there they've required all sorts of other things to be
Usually,
done.
it doesn't go down with your typical anti-glaucoma medications. I mean,
It's
even
got,
if you try to
yeah, once you've got raised epicyclial venous pressure, and once you have this consistent physical compression of the globe, it becomes a
Tagging,
bit more
okay.
difficult.
Thank you. So here we have a 54-year-old male who came for routine eye checkup. There is no systemic illness. Vision is normal. The anterior chambers were noted to be shallow, and gonioscopy showed all around closed angles with some areas opening up to the trabecular meshwork, but scattered PAS is also there. Intraocular pressure is 30 in the right eye and 26 in the left eye. Disc findings were normal. Patient underwent YAG PI, and post PI, usually at PI time we start on steroids as well as timolol drops, that's routine. And post PI the IOP had come down from 30 to 26 and 26 to 24. And patient is still on timolol twice daily. Gonioscopy, again PAS is persisting. These are PIs, fields and OCT normal. So many a time we have these sort of patients where it is an angle closure, it's not yet angle closure glaucoma as such, but after PI it's gone to a chronic phase, it's not opening as such. So now the IOP is around 30 to 25 and in both eyes. What do we do?
First, why is timolol routine? I would prefer a short-acting drug because we are looking at only a short-term IOP
weeks.
spike post-PI. So I would prefer Diamox or something systemically if we can give it, or even primordial stat sort of situation, rather than timolol as routine. Timolol can kill.
Okay.
So it should not come into any routine prescription.
Okay.
So that is one issue. What is the question that you asked me? I forgot.
No, angle closure.
Post PI high pressures.
Post PI not opening. IOP is high.
Post PI not opening, is opening the PTM, the pressure may come down. So I would like to withdraw the timolol and see if that is happening.
Okay.
Any whichever way, PI does not open up every angle that we know since the analysis and ZAP study. 1/4 makes no difference is what the ZAP OCT findings were. So we are looking at following up the patient. And now on the next option is medical therapy. If that fails, we are looking at a surgical therapy. If there's a cataract, we go after that. Otherwise, we go for a trap. I mean, it's that sequence. So we need is a close follow-up here.
You know, Dr. Ronnie presented a beautiful algorithm yesterday regarding, you know, how after PI, you look at the angles, the intraocular pressure, and then make decisions. I'm going to ask you to just, it is very...
Yeah, so I just have one question. Gonioscopically, do you think this is Plato iris or not?
It's not Plato iris.
So it's not a Plato
It
iris.
doesn't have that hump.
It doesn't have that hump. So that's interesting because then there is possibly a significant lens-induced component. Because no. So Synechia are there. So it's a combined. I mean, so the lens is probably playing a significant role. Or a creeping ACG. So those are the two possibilities. 54 is, I mean, maybe slightly young for this to happen because if he's extensive Synechia, then he's slightly young for this to happen. So what's his refraction like? Is he hyperopic or do you remember?
Sorry, I don't have that. Right.
Yeah, so if he's a little bit on the hyperopic side, that could explain the whole thing. He's got a crowded anterior chamber and that's what's causing the problem. I agree with Thomas that I would consider close follow-up. If I'm not happy with the angle opening, if I'm thinking that the synechia are getting more, I would consider an early lens extraction in this man because he's 54.
Yeah.
But the other option that you can consider is just try pilocarpine. 1 drop at night in one eye. Call him back in 3-4 days, take a look at the angle. 54, he may not mind.
Okay.
If the angle opens up well, you can consider that as an option. But if it's not opening too much, he's uncomfortable, just don't even bother.
I think the opening actually did happen because except for the areas of PAS, which is not going to break after doing a PI, then it's actually opened up. So this is
probably wait and
medical therapy
keep on
if
follow.
required, and yeah.
I would add one more thing for pilocarpine. Pilocarpine is probably the best drug for a therapeutic trial. You put a drop, see him again in 2 hours, IOP and gonioscopy can be repeated. You know if it's working or not. And you can ask him about the reading and tell him to go out and come back.
No, but the 3 days, sometimes you will have patients actually complaining of few of the other things that start having their brow aches and all that. So,
I think he said 3 hours during the day itself.
yeah,
That day itself.
That day itself.
Itself. Yes, okay. You get to an idea of what the mechanism.
So my question is, suppose this was an angle which did not have a synechial closure at any point of time, and you did the PI, and after PI the angle did not open up, right? And there is no synechia as such, but you have a Plato iris configuration, right? At that point, what is your option? Does anybody still do iridoplasties and give a trial, or?
Well, we used to do a lot. In fact, if you look at a paper out of Vellore almost 20 years back, almost all the iridoplasties worked in opening up the angle at 1 month. Long term, you do see that they tend to close up again.
Okay.
So you also generating quite a bit of pigment when you do this. So because of that reason, I have sort of stopped doing iridoplasties. I'd rather use the pilo if need be.
I hate getting a thermal laser onto iris. And next thing you know, you look at the slit lamp, it's plasma aqueous.
With
Looks
argon,
horrible.
right?
Okay, thank you. So we have a 57-year-old lady who was referred for further management of a retinal problem as well as for glaucoma control. She is a known hypertensive, 11 years, diabetic for 9 years, and dyslipidemia again for 9 years. She had underwent diode for coagulation in the right eye for control of the glaucoma. She was having neovascular glaucoma, and right eye is currently no PL, corneal opacity with microbullae, shallow anterior chamber. Gonioscopy is not possible, IOP is 56, and disc also not very clear. In the left eye, she is having 6/6 and 6 vision, shallow peripheral anterior chamber with florid NVI. Opening up to, you can see the scleral spur with scattered synechia with new vessels at the angle. IOP is around 32, and disc findings you can see. There is no glaucoma as such, but PDR is present. So this you can see the new vessels on the iris. This is a fundus view. Right eye is hazy due to vitreous hemorrhage. So we have a patient with new vessels on the iris and the angle. The intraocular pressure is around 32 and PDR. Now, we'll
If I may
deal
ask,
with the retina.
problem is tackled or?
Retina, it has to be tackled, yes.
Yeah.
You have to,
As per your case?
at this point, not
Okay.
tackled. It has to go to the retina person, and then they have to do the laser or anti-VEGF,
Yeah, so
and then we have to see.
I would prefer that the retina doctors, because the disc is still good.
Disc is
Even
good.
though patient is one-eyed, we have to be doing a very close follow-up and probably an aggressive thinking, but definitely first the retina has to be tackled whichever way, either an anti-VEGF followed by a tight PRP, and then along with that we should start our medical therapy, and once the retina is settled, still the pressures are high, then I still think of a trabeculectomy. I still are not great advocate of going in for a tube surgery as a primary surgery in
Okay.
NVGs, considering the disc being normal,
Normal.
and things.
Yes. Any role for medication? Anybody would? Like
Medication,
once you
yes,
give the
but-
anti-VEGF and the
but
vessels regress, do you wait?
I mean, in this particular case, the first thing is I call up the retina person sitting opposite my room and ask him to give a PRP on that day itself. Because this is a ticking time bomb. 6/6 vision, NVI, 32.
Other eyes lost due to
Yeah,
this.
but this eye will, you can, if not for the very aggressive PRP and destroying all the oxygenic, stimuli, this will go into a very bad situation in a month's time, much less than a month's time. So that would be the first priority, obviously, and starting him on medical management at this stage and a very aggressive PRP. Once the PRP is done, all the retina has been tackled, and then if the pressure is not getting controlled, my general tendency to decide on which surgery will be depend on any presence of residual NVI.
Okay.
If there is residual NVI, I would straight away like to do a tube itself.
Rather
because-
than a trap.
Rather than a trap. If there is no residual NVI, yes, a trap. But usually these will, if the pressures are not controlled, there will be some residual NVI, and therefore in most situations this will end up with a tube surgery in my experience. So.
Okay, I would like to underline that when you have an open angle NVG, it's an emergency.
Okay.
Especially if it's a vein occlusion NVG, you got less than 2 weeks before he goes into no PL situation. PDR, you get a little more time generally. But open angle NVG, PRP as soon as possible, anti-VEGF, and this PRP is not a routine PRP, call him back every 3 days and finish it off in 1 week. Routinely, the retina people say one session now, come back next week or the week
Yes,
after.
yes,
That
yeah.
is not on. We have to make it clear with the retina people, this PRP has to finish in 1 week. And within about IOP, we treated medically as well as we can for about a week as this is going on. At the end of it, you have said opening up. If there's an ACG involved, if pressures are normal at the end of it and or with medication and no NVI, go ahead, do a PA. That
Okay.
also has to be thought of. You may have a second problem sitting there. If there's a cataract, when we plan the surgery, get rid of
Cataract
that
also.
also. And I don't mind doing a trap in this patient, but if a tube, the problem is you may hit the cornea with the shallow AC. So that's another issue there. But if you're doing a cataract surgery also, tube can go in. But in general, the NVGs do better with a posterior bleb than an anterior bleb because all this hyperemia, new vessels, etc. is more and the walling off is more. So I am biased towards a tube for the NVGs, but trap does work also. Trap with mitomycin.
Yes. Ronnie sir.
Yeah, so it depends on the angle because as Thomas said, you said opens up. So if you think that there is no angle closure component, it's entirely an open angle and you are still in stage 2, basically you have sine K but the angles are open. And aggressive PRP and anti-VEGF, these vessels may regress completely. You may actually get him under control without medication,
Okay.
provided you can be aggressive about it. I mean, I've seen patients 10 years after they presented with NVG. But because you aggressively manage them, they are on no medication, they are perfectly okay. He has some sine K, so that is one of the issues, and one-eyed. So the first thing is to get the retina guys to treat this as an emergency. If there is additional closure, then once after a week or two when some anti-VEGFs have gone in, just do in a PI.
Okay.
And you have time because the pressures are not too high and you monitor the angles closely. If the monitor angles are not zipping up, just try and give it time. If it settles down on its own, that's the best possible solution that you can get. Because NPG is also one of those situations where you can land up with hypotony. Because this process is going to resolve over time once
Yeah.
the retina guys have done it. So then you'll end up doing an aggressive trap with mitomycin and then suddenly you find IOPs are 5 at the end of 6 months.
Because you don't know how much of the aqueous is inflowing.
Yes, not only that, because by the time the angle has recovered, so you have
Yeah.
good outflow and you have a trap
Lots
sitting
of
there.
outflow.
Thanks to the PRP, the inflow will also start coming down.
Okay.
Typically, you would like to wait a month. But you have to keep them on close follow-up in between because the disease can continue progress in that time. If you can manage to make sure that the progression is not going to cause any problem in terms of additional Sainicke and other things, then you can wait. But otherwise, it takes a month to 6 weeks for you to see an effect of a PRP. And you will see beneficial effects going beyond that too.
You can see a direct correlation between the NBI regressing after PRP and the pressures coming down. It's usually a very direct correlation as long as the angles have not zipped up too much, as it is in this case, which the angle is relatively open. So the most important thing is to get that PRP if possible on that day itself. Because I've had people who sometimes call me and ask me what is to. That is the most important thing here. No, first PI. I don't know to me.
You cannot have a hard and fast thing in this situation. It's going to be evolving very, very fast. You don't know how this patient is going to evolve. So we know the retina is a problem. Anti-VEGF works a little faster, so we want that going in. And PRP is a more permanent solution, so we want that going in. First session of the PRP should happen on the same day, whether the patient has got money to pay for the bill or whatever, that has to happen. And the next one as soon as possible, 2 or 3 days down the line. 1 week the PRP is sort of completed, then they can fill in if they need. Our guys fill in 2-3 times for the NVGs after all the sectors are finished. And you get the real effect of PRP in about a month. But sometimes you don't have time. This 32, by the time the PRP is complete, in between the process is zippered up and you have a 50 on the next week. This is a one-eyed patient, 6/6 vision. That would have dropped to 6/12 by then. You can't watch the patient go down. You may end up doing surgery before that.
Yet, don't forget that you have to keep the patient on topical steroids because with this aggressive and short-term PRP, you can land up with an effusion, which will compound the problem. So you have to keep the patient on topical steroids the moment you start the PRP.
If there are residual NVIs and we are contemplating surgery a week before, an intravitreal anti-VEGF is absolutely useful.
I think we'll go on to the next case. He's a 67-year-old male who came for routine checkup, known hypertensive for past 7 years. Vision is 612 N6 in the right eye and 618 N6 due to cortical cataract. Open angles, IOP is 23 in right eye and 33 in the left eye. Normal disc findings. These are the photos, the fields, the OCT, and the corneal thickness around 513 in the right eye and 510 in the left eye. So probably a case of ocular hypertension. And how closely would you follow this patient up, or would you start off treatment? IOP is around 30 plus in the left eye. No family history, no other systemic apart from hypertension.
So I would just ask him 2 questions. One is whether his hypertensive medications have been changed recently.
Okay.
Because suppose some of these patients would have been on beta blockers for a long time and now it's changed. So
that
they
would press the IOP up.
so that might, the thing may have been going on for longer than you know. The second thing that I would really press and ask them is whether they've been using any topical steroid ointments.
Okay.
Because I find that so common. And sometimes that's the only thing you need to do. Otherwise, yes, he's in
30 plus IOP.
30 plus IOP in the left eye. I would consider treating. I might think seriously of doing an SLT. In that eye,
okay.
in that eye at least. The right eye, I would probably just observe.
Okay.
Actually, at 30 plus IOP, there's one more risk, not just glaucoma, vein occlusions.
Vein occlusions.
So definitely the left eye needs treatment with this pressure. I would probably treat the left eye and watch the patient for something to happen in the fields or OCT for some over a period of time.
Yeah, as I agree with them, for a left eye, definitely a treatment. Probably we can try a diurnal because this is just a one reading, but again 30 is a little on a higher side, and patient seems to be having cataract in this case. So probably we can re-evaluate after the cataract extraction again the IOP and then decide on whether to continue, whether the patient really needs the glaucoma medications to be continued or not. That will be my take.
Practically, I would end up treating the right eye also. This is practical. What I mean to say is, when somebody comes with pressures like this and I tell them your nerve has not been damaged, but there is a clear evidence that in the left eye because of the high pressures, the risk of damage is quite high over the next few years, and therefore I have to treat you. And most of them will want treatment on the right eye also.
Okay.
That is the only thing practically. I mean, from a strictly theoretical perspective, yeah, 23 millimeters of mercury, you don't. But how many patients will tell you that, okay, I will put medicine only in the left eye and I will wait to see, whether, whether I can reduce whether I'm okay with the theoretically double the risk of progression to glaucoma in the other eye. So in practical purposes, if you are treating the left eye, I will probably end up treating the right eye also.
And cataract surgery, how much of an effect do you think would have on IOP? Or would you say it as
wide open angles,
much,
ocular hypertension, not much.
They do say you get a small dip in IOP with cataract surgery, but it is transient.
It
so you
won't
can't
last
rely
long.
on it.
Yes.
It's something like 2 millimeters dip, and 3 months later it's back to where it was. So you can't rely on it. Cataract surgery, again, I would delay till I'm sure that I can get the pressure down to somewhere near 20s at least in the left.
Okay, okay. I think we'll go on. We have a 78-year-old lady who has complaints of swelling, watering, aching pain and redness in the right eye of 5 months duration. She is a known hypertensive for the past 2 years, no other systemic risk factors, no other family history. So vision in the right eye is 6, 9 and 6 in both eyes. Anterior segment shows periocular fullness, no palpable mass, but moderate proptosis with diffuse congestion and chemosis. Dilated episcleral vessels with corkscrewing and NS2 with cortical cataract. Left eye has just an NS2 with cortical cataract. Gonioscopy is open. Intraocular pressure is 27 in the right eye, 18 in the left eye. Disc shows a congested disc with ill-defined margins and tortuous vessels. Left eye appears to be normal. So these are the photos. Moderate amount of proptosis with corkscrew vessels in the right eye, some amount of chemosis. I couldn't get a proper fundus photo for this patient. Disc photo rather, this is a fundus photo. Fields appear to be okay, scattered scotomas in the perifoveal region. Yes, so this is a lady with proptosis in the right eye, no history of thyroid eye disease. Yes, so how do we go about this?
This looks very much like a low flow fistula, low flow CCF. 74-year-old presenting unilaterally with corkscrewing, that is arterialization of the veins.
So angiogram would be the
a CT or MR angiogram should be the investigation of choice. And if they detect, I think they should detect because it looks very much like that. If they detect it and then the further treatment, then the further treatment would be left to the discretion of the radiology, interventional radio people. Sometimes they do use these compression maneuvers, massage, ipsilateral, this thing, carotid massage. Sometimes, and sometimes it works. And otherwise they will coil embolize the vessels.
The vessel, yes.
That is usually going to take care of the problem. And they will also want to know, I think the problem with these low flow CCFs is that they are not likely to have any permanent neurological issues. All the problems are likely to happen to the eye itself and nothing else. So they will basically liaise with you with regarding what is happening to the eye, and that will probably sometimes, for example, they might see if we tell them that the pressures are medically under control and there is no disc edema or disc damage as such, they might actually go for this compression maneuvers conservatively. But if we say that the problems are advancing, then they will go for embolization also. So
I would just add on an orbital ultrasound because that's accessible to you right there. Because sometimes you will actually pick up a surprise on that. There may be a small mass, a cyst or something which is causing that. So it's worthwhile to do that before you send them for everything.
In many cases, we do this angiogram and we don't find any flow related anomalies. And many a time the IOP rises also. So have you had any situations where you had to intervene, like maybe do a surgery or something like that, trab or something?
Yes, so sometimes with raised epithelial venous pressure where you cannot identify a cause, you have to do a trab. So when I do the trab, I typically do a prophylactic sclerotomy also at the same time because you can land up with an effusion. Prophylactic sclerotomy hardly takes any time to do its. So I usually tie it down tight, and they do quite well actually.
Many young patients usually they come with single-sided this type of vessels. This lady is old and she's having hypertension also, so probably it's a more of a.
Yeah, so young people a little bit more aggressive about investigation. Sometimes you do the MRI, you don't find anything, then you do a DSA. You see whether you can pick up something with that.
So you wanted.
Episcleral venous pressure trabs, the pressure lowering also may not be like what you'd expect with any other trab, because from the trab reservoir also it has to go through the same veins which are at high pressures to get out. So that is also an issue. Of course, chance of effusion, bleed, etc. is more. So a sclerotomy in place would be a good idea to start with before you go for entering the anterior chamber.
Okay.
When you have done cases like those with a sclerotomy, have you noticed that in the post-op that area has undergone a little chemosis which actually showed that there was some effusion? Have you noticed something like that?
You do see it sometimes. You do see a little bit of bulge, but because it's a very, very slow ooze. It's not like it's collecting on table and coming up. So most of the time you won't have anything much, but sometimes for the first few days you'll see a little bit.
I think they do something called scleral window. Dr. Mahesh is he likes scleral window. He doesn't really like a sclerotomy. So he does a scleral window, which is probably little more safer and rectangular he does.
Full thickness or partial?
No, it's a partial thickness. He takes a partial thickness sclera, and then after that once there is a small, I think uses a 27 gauge, and that leaves it like that. So it doesn't make much of a difference, but I think
You have to go up to this choroid.
This is sclerotomy that they're talking about. Partial sclerectomy with a sclerotomy. But a 26 gauge sclerotomy is not enough.
Yeah, so
you need a nice slash.
So you need to do, the reason, so when you're doing a sclerectomy in nanophthalmos, I do that. I do a sclerotomy. And sometimes if it's really bad, you even try to do you deroof the vortex decompression. That's very far posterior. That's a really extensive surgery. But otherwise, a sclerotomy is something that most glaucoma surgeons can do. We are used to cutting the sclera.
Nano, I actually take off a triangular full thickness. It's not sclerectomy, sclerotomy. It's a full sclerectomy.
In nanophthalmos. Here we have a 38-year-old male patient who was referred for YAG-PA. He had complaints of decrease in vision and pain in both eyes of 2 days duration. He was diagnosed to have an acute attack, and he was started on treatment for acute attack with Diamox and Timolol eye drops. So when he came, he had a vision of CF 3 meters, which was improving to 6.9 with a -4 diopter cylinder in both eyes. Shallow anterior chamber, sluggish pupils, gonioscopy showed aposternal closure, IOP is 30 and 26. Disc findings were normal, so this was the photo and the UBM. Now, on probing, he gave a history of drug intake for headache 2 weeks prior to developing this symptom. Yeah, so how often do you get this drug-induced angle closures?
It's not uncommon, but I think even Diamox, I mean, this patient was started on Diamox after the onset of diminution, because
That
there are
was 2
people,
days.
Diamox itself can cause, the same drug-induced angle closure.
Yes, yeah.
In fact, recently there was one case, it's not here, okay.
He had the headache 2 weeks ago, started on medications, and
So
2 weeks.
you're thinking that he might have been given topiramate or something for the headache? Is that?
He was actually,
Acha.
but yeah, this is the history. Like he was referred for PI, thinking that it was an ankle closure.
Yeah. This is definitely the myopic shift is also telling you
Myopic
clearly
shift, yes.
that this is a drug-induced angle closure, and therefore PI has not much of a role here.
Yeah.
Yeah.
When you see a
Offending drug.
bilateral closure acute, think of a drug. And topiramate is notorious among ophthalmologists for this. But that is not the only drug. Diamox, which we use, is also in the list. And there's a list of around 60 drugs that have been reported to have this.
The most common-
Cough and cold medicines, antihypertensives, a lot of things are there. So go back to the net and find out if any of the new medicines are in the list.
The most common drug reported in literature is Diamox, not topiramate.
So we did a UBM and we saw this effusion, and once we stopped the medicine, it resolved. Did you ever have to have a case where that did not resolve following stopping the medicine? Not.
Did not resolve in terms of unfortunately, the worst eyes I have seen are patients a month after this thing has happened who have been put on pilocarpine.
Okay.
It throws up such terrible inflammation, so much of pigment loss. They develop a membrane which sort of zips up the angle. So that is the one situation where sometimes it's very, very difficult to go in and do anything.
In this case, pilo will make it worse.
Yeah, pilo makes it
Yes,
worse. Pilo
yeah.
just makes it worse, compounds the inflammation because they've got a ciliary body effusion on top of it.
People are hesitant to give cycloplegics.
Yeah. So
I got a call a couple of weeks back that a person had a PI for an angle closure, which he was advised a PI in Cochin, and when he came to Trivandrum, he got his PI done. And the very next day, the patient called the surgeon up and said that the vision had dropped significantly. So the patient comes in and they find this myopic shift and everything. And he calls me and tell him, you have given Diamox yesterday, most likely that must have caused this. Stop the Diamox and give him cycloplegic drugs. He is worried so much. Are you sure? No, yeah, you can give cycloplegic drugs. But it's very, very hesitant.
I think the biggest clue for everybody is that bilateral angle closure plus the myopic shift. That itself should give us a clue. It's in central shallowing. So these things should give us a clue that probable cause is drug induced and you should not use pilo. So
I had one patient who had glaucoma flecken actually due to drug induced ankle closure. I think this is our last case. So it's a 41-year-old male patient who was working abroad actually, and who was diagnosed to have glaucoma 2 weeks previously. He went there complaining of decreased vision 2 weeks previously, and glaucoma workup was done at the hospital and was given all these medicines. So the best corrected vision was 6/6 both eyes. Right eye showed diffuse conjunctival congestion with RAPD. Left eye was normal appearance. Cynical closure was present in the right eye. Intraocular pressure was 28, and disc findings showed advanced glaucomatous optic neuropathy. Gonioscopy in the left eye was open, IOP was 10, and disc was normal. So this was done elsewhere, and these are the investigations done abroad. The fields were done here. Left eye, early changes, nasal step. Right eye, advanced, C10-2, advanced glaucomatous changes. Now, this was taken after we stopped a few medicines. He was having severe chemosis with follicular conjunctivitis in the right eye. Left eye, there was no medicine, so it appeared normal. This eye appears to be more clear than what it was when he presented. So we have a young individual, unilateral again, with a somewhat closed angles, and IOP is high. on all medicines. Pardon, sir? Slit lamp photo. I don't have a slit lamp photo. I only have anti-segment.
Being unilateral closure, was there an anisometropy or something to explain the other eye being
No,
open?
not much.
Not really.
No.
Okay.
And no history of
UBM.
any like trauma, nothing.
You can see the retina well also, no effusions, nothing. I mean, this is unilateral, complete cynical closure. That is why.
He is a very recent guy. He just came around 2 weeks ago.
How is his endothelium?
Endothelium is good, sir. I mean, I don't have a photo. I have not done
Because
a
sometimes
study.
an atypical eyes
Okay.
formophrastic can present like this.
Okay.
So that's why if you, I mean, the pupil size is looking similar, but I'm not sure whether this eye is a little larger than the other eye, because that can sometimes be the only sign that you get. And it may be worthwhile, is the iris in apposition with the lens? Because if it's lifted off, that's the other
These
sign.
all
that-
the same eye.
These are all the same
All the
eye.
same
correct.
eye.
Yeah,
It's all the
eye,
same eye.
Yeah, then
They have not shown us the left eye.
Left eye, I didn't take the photo. I
So,
don't have the photo.
So I would actually consider looking at the endothelium, looking at whether the iris is lifted off, doing a UBM, because young unilateral closure is usually
Okay.
secondary to something else.
It's very rare to have, other than in an anisometropic situation or a secondary cause, you have one eye cynical closure all around and the other eye being totally normal open. So we really have to hunt down a cause that is
cause for
pushing
this.
from behind or rotating up the ciliary body. So UBM, ASOCT is not going to give us much. So UBM is the way to go for now. Unless you can find something clinically, uveitis, eyes, something else that
Okay.
causes a synechiae, which can happen only in one eye. Herpetic disease,
Okay.
any KP anywhere, you have to hunt for something secondary.
Suppose you have ruled out, say UBM doesn't show anything significant, and suppose this is just simple cynical closure and high pressures, and an iridotomy has not been done.
Iridotomy was not done.
So, I mean, the question is then how do you proceed? Unilateral, RAPD, near total, everything. So,
Yeah, advanced glaucoma.
I mean, suppose we have to do intervention. That my question is, trab or Pego trab.
Okay. Assuming that we don't find anything secondary after our looking around, 4 drugs not controlled, you're looking at trap.
Okay.
Absolutely not controlled. Pressure is high. You got
Still
advanced defects which warrant a low teens IOP. There's no question.
During the trab, will you take out the lens? That is the question.
I would do an OCT and look for a lens fault to give me a reason to take out the lens. Otherwise, I leave it there.
No, I would probably leave it there because the eye is a little inflamed.
Okay.
So I would try to do a trap. I mean, tell him that of course you might have aqueous misdirection and everything else. But if you're fairly careful on table, you can manage to get away with it. He's young, I mean, he still has some accommodation in that eye, but you want to knock it off.
I did
And
go ahead.
suppose as part of the ASOCT, you have now found a volt of 1200. Then
That's why I wouldn't do the ASOCT.
Actually, I did do a trap, and this is the first 1 week following that, and I landed up with blood leak. He's on BCL now. I mean, otherwise okay. His
This will
IOP has
settle.
come
This
down.
is an HT.
Edge leak.
HT will settle.
Yeah, I mean, it's a very recent case, so I don't have further follow-up on this. Thank you. That brings us to the end of the session. Anybody has any questions regarding?
It's rare. So under 30, you are not likely to see bilateral cynical
So
angle.
what else have to be looked for, sir?
Look
when
for
you
a
have
second.
such
Look for secondary cause, old uveitis, accent field rigor type of picture. Very, very rarely bilateral eyes. Even though eyes is supposed to be unilateral, sometimes, very rarely you see bilateral. Look for a secondary cause, most times you will find one. So if you can't find anything, definitely get a UBM done. Young women, sometimes you get this type of a picture. A loose lens, you can get that picture. But it's extremely, primary angle closure glaucoma is, once you have ruled out everything. Yeah.
Nanopositive.
Yeah.
Look for all the secondaries. It's a little early. And finally, once you find nothing, you have to call it a PSCG.
But it's very rare. It's very, very rare to find. Sometimes what happens is you can get pseudocyst, you can get iris, pseudoplateau iris, you can get this.
Yeah.
But bilateral.
Yeah, you can get bilateral.
You're talking about zippered angle, right? Not
Yes,
one or two
yes,
synechiae
no,
here
no,
and there.
No,
Okay.
zippered.
Then you have, secondary rolled out, only then you can call it a angle closure, regular angle closure.
Again, same question that I asked, is the iris lifted off the lens?
No.
The lens is...
Actually, when you see in the slit lamp, first look, it looks like it's not going to be an angle closure. But only when you do the bone, you see so much of synechiae, that kind of pictures.
Then you have to do a UBM because typically with the cysts you can get this type of picture.
Even a plateau takes some more time. You need to give them some more age for synechiae to occur.
This is one 24-year-old boy, sir.
You sure you're looking at synechiae and not an anteriorly inserted iris?
No, it's a synechiae itself.
Because that can be there. You can have a frustrated congenital glaucoma that's planning to raise the IOP later on with a very
My
anterior.
another one doubt is, if a patient has a glaucomatous optic atrophy, do you advise, means no PL vision or maybe HM vision, do you advise to use multiple agents to maintain IOP less than 30 or something to prevent vein occlusions or something like that?
If the starting IOPs are 40, 50, you know that cornea is going to decompensate. And you know that they have a high risk of vessel occlusion. So you are ultimately going...
The only thing, he doesn't have vision, otherwise eye is normal.
No, what's the pressure? What's the baseline pressure?
Maybe 45.
So 45, 50, your cornea will decompensate with time. You keep him on one combination, bring him down to 30. You don't try to put him on 5 drugs. So that is why I'm not going to be more aggressive than that. But if he already has corneal changes, then keeping the pressure down is the one thing which is going to prevent him from landing with a painful blind eye.
Let I throw one more thing in. You said hand movements. I would do a confrontation fields and see if there's a significant amount of temporal field which is there, which is required for ambulation. If he's got some 10 to 20 degrees plus of temporal field, he knows that as he's walking along, he's not going to bump the shoulder onto the next person and get them to think about other things. So that also is important. Even that I would consider as useful vision. It's not 6'9", 6'6" alone. I would be aggressive if the temporal field is significant. Medical treatment, trap, whatever. Otherwise, unless he's got pain, I don't see any reason to intervene. No PL, unless he's got pain, I don't see any point to intervene. I would even try to withdraw medications and see if the pain occurs. And as and when it occurs, cyclodistraction.
I'm asking, sir, just because if the IOP is in 40s, whether they will go for CRV or NVG and all those complications and end up with
all
a
those-
painful eye.
We deal with it that time.
Yeah, probability is there. As sir said, like it's better to bring it down, not to low teens or something, at least bring it down to a considerable, low IOP. And as, don't underestimate this hand movement vision. Please, that is also a useful vision for that particular patient.
The other thing you have to take into account is whether this is unilateral or bilateral. If it is bilateral, he's already using a couple of drugs in the other eye, there's no harm done in putting it in this eye also. If it's a unilateral blind eye, then of course it becomes difficult to convince the patient to use something because he's not getting anything much there. It depends entirely on the level of IOP. For me, high 40s, 50s, I would keep them on at least one combination.
I think it's already time. There's one more session. Thank you to the panelists and thank you very much for the audience. Last day glaucoma session, not easy to find audience. Thank you.